Welcome back, everyone. We're going to continue our Neurologic series while discussing altered mental status. Altered mental status is one of the most common EMS complaints that we go to, and aside from stroke and seizure, is the most common neurologic emergency. Altered mental status can be described as when the patient isn't thinking clearly or is unable to be aroused or awakened from a state of slumber or decreased responsiveness. In some cases, these patients will become unconscious, and in others, they may be alert but confused. There is an acronym that we used in assessment, and we discussed an assessment called AVPU, where we rate a patient's level of consciousness. AVPU is specifically designed to discuss their consciousness, while we use a term alert and oriented or orientation to describe a person's cognitive function. These are important terms to be able to remember, as you'll need them in documentation and when communicating with other healthcare providers about the condition of your patient and their current presentation. With AVPU, the A stands for the patient is awake, and this would mean the patient is engaging in normal conversation, they're maintaining eye contact with you, and they're able to hold up their own body weight or maintain a posture and seated upright or standing. V stands for a verbal level of responsiveness. This means that the patient responds to you once you stimulate them with a forced verbal response, whether that's a name or a noise. They become aroused or awakened when you verbally provide stimulus. The P in AVPU stands for pain, and this is when the patient responds to painful stimulation. And this response isn't always a complete and comprehensive response. They may moan or withdraw from painful stimuli, but you do gain a response from them with some painful stimuli. And then the U in AVPU is for unresponsive, and that means that a patient does not respond to verbal or pain. The orientation scale we typically use in EMS is an orientation to person, place, time, and event. And this is commonly abbreviated when a patient is alert and oriented to all of these as A&O times 4. Remember that if you're going to use the term A&O times 4, you have to have assessed whether the patient was actually oriented to person, place, time, and event. There are some simple questions you can ask the patient to help gauge where their orientation is. So, for example, person, does a patient know who they are or their name? This can really be achieved very simply by, when you introduce yourself as a provider, asking the patient's name. Does the patient recognize where they are in space? That's the place orientation. Does the patient know the day or date? That's the time orientation. Keep in mind when you're assessing a patient's orientation to time, though, some patients, under normal circumstances, may not know the date of the month or the day of the week even. This is particularly true for patients who don't live on a standard Monday through Friday work schedule. So, for example, elderly patients or retirees or even young children. You can use other clues to help determine their orientation to time, such as their awareness to current events, such as political elections or sports games or near holidays. Event is the patient's orientation or awareness to what's currently happening in and around them. So, are they aware while you're there as an EMS provider? Do they know what happened? The interesting thing about the degradation of a patient's orientation is it's a linear process. As a patient becomes more and more disoriented, they tend to become disoriented first by the event, and then they lose event and time, and then they lose event and time and place. And the very last thing that a person tends to lose as far as orientation goes is their awareness of self or person. Let's look at some causes of altered mental status. There are lots of things that can cause altered mental status specifically. If you'll remember from our discussion in the anatomy and physiology, and even in the respiratory chapters, the brain is a large consumer of oxygen and sugar and glucose to make ATP. So some of the leading causes of altered mental status are an insufficiency in those products. So for example, hypoglycemia or hypoxemia. The good news for us is we can assess for each of those. We can assess for hypoglycemia with a blood glucose test. We can test for hypoxemia with the SpO2 monitor or other assessment skills. Other things that may cause altered mental status include things like intoxication, delirium, drug overdose, unrecognized head injury, things like brain infections, body temperature abnormalities, either hot or cold, brain tumors, overdose, and or poisoning. We'll see another acronym shortly when we talk about coma called AEIOU TIPS. And we'll discuss that further, but that's also an acronym you can use to help remember things that may cause states of altered mental status or coma. Syncope is a brief episode of loss of consciousness. So if an altered mental status is a period where a patient may not have complete cognition, but they may be alert or alert to verbal or painful stimuli, a syncopal episode is where a patient is completely unresponsive for a short period of time. Syncope can be often confused with seizures, but they're very different. Syncope is more akin to fainting, and it typically occurs while the patient's standing, but the patient can be seated. And seizures can occur in any position. And we'll talk more about seizures in subsequent lectures. Fainting is also not associated with a postictal state, which is the state of confusion that exists after a patient has a seizure. The pathophysiology for syncope is a sudden and temporary, the key word there being temporary, loss of consciousness with the loss of postural tone. That means the patient can no longer hold themselves up. It's typically caused by a short interruption in blood flow, and we as providers need to be able to determine, or at least have an index of suspicion of what caused the syncopal episode, because ultimately that's a sign of a decrease in cerebral perfusion. So things to assess for and common causes of syncope. We need to be able to assess the patient and determine if another episode is coming on or if this episode has ever happened in the past. We need to be able to determine if the patient was in a seated position or a standing position. As a reminder, most syncopal episodes occur in transition from seating to standing, but that also can complicate things, and we need to be able to assess for trauma to make sure that if the patient fell, they didn't experience any significant trauma that may need to be treated as well. Vasovagal syncope is typical in younger adults, and this happens when a patient is bearing down. It can happen if a patient is undergoing strenuous physical activity or bearing down like they're having a bowel movement for an extended period of time. In older patients, cardiac dysrhythmias can also cause syncopal episodes, which is why syncope should carry a high index of suspicion. We can also have things like transient drops in blood pressure or a reduction in the brain's oxygen supply that can result in the syncopal episode. Prodromal symptoms, and this word prodromal means signs that occur just before a syncopal episode in a patient. The patient may experience dizziness and weakness, some shortness of breath, chest pain, headache, loss of vision. If the syncopal episode is associated with chest pain or shortness of breath, it's going to be important that we include a cardiac assessment on these patients. And if you're a BLS provider, you may want to consider having an ALS provider meet you en route if you don't have one available on scene. Incontinence or a loss of bladder and bowel function is also common during syncopal episodes. Not common, but possible. As far as management for the syncopal patient, as mentioned previously, we need to make sure that there's no trauma associated. If the patient fell from a standing position, did they strike their head on something? Is there a potential for subsequent trauma or secondary trauma that may need to be addressed and treated? Focus first primarily on blood pressure and cardiac causes, as these can be the most risky for the patient. For advanced providers, we should be conducting continuous ECG monitoring for a patient who had a syncopal episode. Again, this is to ensure that the patient isn't entering into a transient dysrhythmia that may be incompatible with life. We also should evaluate blood glucose and oxygen saturation to help rule out hypoglycemia or hypoxia. We can obtain orthostatic vital signs on these patients, and this means assessing the patient's blood pressure in 3 different positions: in the supine position, in the semi-Fowler's position, and then once again in the standing position, looking for significant increase in heart rate or widening of the pulse pressure for those patients. Make sure that you provide emotional support. A syncopal episode can cause confusion for the patient, and they may be scared or panicked, and then transport to an appropriate facility. Okay, let's talk about coma for a little bit. If a syncopal episode is a transient loss of consciousness, a coma would be a persistent state of loss of consciousness. These are often patients that are only responsive to painful stimuli or unresponsive. And as I mentioned previously, the AEIOU TIPS acronym can help you kind of systematically work through an assessment to ensure or help identify and correlate causes of this altered mentation state. First of all, being alcohol and acidosis. Alcohol can certainly cause states of slumber and can reduce a patient's level of consciousness and should be assessed through history. Epilepsy or seizure conditions, endocrine and electrolytes. Ask bystanders if the patient has a history of seizure or use clues from the patient's medication list. Insulin serves as a reminder to assess for hypo and hyperglycemia. That can be assessed through evaluating the patient's blood glucose level and treating accordingly. Opiates and other drugs. We will assess the patient's pupils as well as get a history from the bystanders and clues from the scene around for opiate use. Uremia, trauma, and temperature. We should be good historians and make sure that we're assessing the scene to make sure that there's not underlying trauma for the patient. Remember, as we discussed in assessment, if the patient is unresponsive and unable to answer questions, and you cannot identify the immediate cause of the patient's presentation, we need to engage in a full head-to-toe assessment. This includes exposing the patient and evaluating for trauma. Make sure to maintain the patient's modesty whenever possible. You should be assessing temperature at the core temperature for these patients for both high temperature and low temperature states. Infection. The temperature can help be a clue for that. Patient's current medication, the patient's history and surroundings may also have some indicating factors. There also may be things like psychogenic issues, such as conversion disorders, and we'll talk some more about those when we talk about seizures. And then you have items such as shock and stroke. Is it a syncopal episode? Is it transient? Things like space-occupying lesions within the brains, or more concernedly, the subarachnoid hemorrhage, which we'll talk about in the stroke section of this lecture. As far as pathophysiology, we need to make sure that we get the history of the present illness, and it's going to be vital to help us determine what that underlying cause is. We need to look at things like the speed of onset. Is the patient in a deteriorating state over a long period of time that terminated in this coma state that you were then called for, or did it occur rapidly? And we need to make sure that we determine when the patient was last seen normal. We'll discuss stroke assessments in the stroke lecture, but this is where we're sort of getting with that idea. When we assess a patient with a coma, we're going to use a Glasgow Coma Scale. This scale is just designed to help us gauge how deep or shallow that coma level and that core brain function is. On the Glasgow Coma Scale, we divide the scale into 3 sections: eye-opening, verbal response, and motor response. Each of those sections start at a 1 and go to a 4 for eye-opening, a 5 for verbal response, and a 6 for motor response. This means that patients can have the lowest scale of a Glasgow Coma Scale would be a 3, while the highest would be a 15. Again, just like we discussed when we were discussing AVPU and orientation, the Glasgow Coma Scale does not assess cognitive function or the ability of the brain to engage in reasoning or discussion or have cognitive awareness. It simply is measuring motor control as a response to brain function. So when we move to assess the eye opening, we'll observe the patient. Do they have spontaneous eye opening? Are their eyes open and engaged? If so, they get a 4. If they open their eyes to sound, they'll get a 3. If they open their eyes to pain or pressure, they get a 2. And if they have no spontaneous eye opening, their score in that section would be a 1. For verbal response, if they have oriented conversation, in other words, they are engaging, they sound normal, the words are articulated correctly for the patient or at a normal baseline for that patient, that would be 5. If the patient is providing confused words, so perhaps there is some disorientation there, they would receive a 4. If they're able to mutter words, but the words may be not the appropriate words, and I don't mean words that are socially inappropriate. I mean, if you ask them to identify a family member and they provide the name of a fruit or a dog or their bed, words that wouldn't make sense under any context, that would get a 3. If they're unable to articulate words but are making sounds, this would be a 2. And if they have no verbal response, they would receive a 1. As far as motor response, if they obey commands, they would get a 6. If they localize pain or injury, that would be a 5. Normal flexion, and this is something also known as decorticate posturing. That's where the arms and legs, or more specifically the arms and hands, are moved in toward the core of the body. If you think of a vampire sleeping, this would be normal flexion and would be a 4. Abnormal flexion or extension, so where the hands are turned outward and sort of moved away from the midline of the body. We call that decerebrate posturing, and that would be a 3. Extension would be 2, and then no motor movement would be 1. When we're looking at managing coma patients, we need to make sure that first and foremost we're supporting vital functions. So evaluating things like airway patency, respiratory rate and depth, and then ensuring adequate circulatory status and considering things like oxygen for the hypoxic patient. Once we maintain vital functions for that patient, the patient should be transported to an appropriate facility because patients may need further evaluation such as urine and blood analysis, radiography, computed tomography or CT machines, and MRIs. The underlying goal for these patients is not often to identify and correct the underlying cause, but we should assess for underlying causes that we can correct, such as opioid overdose or hypoglycemia. Advanced providers should be present for patients that are in a state of coma or unresponsive, and continuous cardiac monitoring should be applied.